So Mr. Smith is a 45-year-old white male with a past medical history that's significant for type 2 diabetes, hyperlipidemia, smoking, and obesity. His family history is significant for type 2 diabetes, hypertension, and CAD. And he's here today because he was referred by his primary care doctor for management of his new onset diabetes.
So my patient is Mr. Smith, and he's 45-year-old white male, and he has, he's obese. His BMI is, oh shoot, I didn't write that down, but I'll look that up for you. Okay, so, but I know he's obese, and he has diabetes, type 2 diabetes, hyperlipidemia, and he smokes a lot. He is seen today by us for diabetes management.
He weighs 308 pounds. His BMI is 41.8. For his diabetes, he was diagnosed about 1 month ago. His A1C was 9.5. He was started on metformin, and his eGFR was greater than 150. He states today that he's taking metformin at 1,000 milligrams twice a day, and he's tolerating it well, no side effects, and he doesn't miss any doses. His diet is improved, but he still eats some fast food and lots of carbs. His average blood sugar fasting is 135, and 2 hours after supper averages 225. His goal A1C is less than 7, fasting blood sugar less than 130, and 2-hour postprandial blood sugar less than 180. Given the recent cardiovascular data, the low risk for low blood sugar, and its ability to target postprandial blood sugars, I want to start Victoza on him, as long as his insurance covers it. Sulfonylurea and insulin is probably not appropriate given the ability to cause weight gain. We also provided nutrition education to him as well.
I wish I had his BMI. Dang. Okay, so as far as his diet goes, he eats really, really bad. So he told me that on his diet recall that for lunch today he had Bojangles, and he ate a Cajun chicken filet sandwich or a biscuit, and he had the fries and a sweet tea, because of course, you know, you can't get that without a sweet tea. And then for breakfast he had he ate at home, but he ate bacon, egg, and cheese sandwich on white bread. He had 2 of those and a glass of milk, and then he also had 2 cups of coffee. And then last night for supper, he had, well, wait a minute, he had a snack. At bedtime, he eats a half a bowl of ice cream every night before he goes to bed. And then for supper, he had barbecue ribs, potato salad, coleslaw, a couple of dinner rolls, and sweet tea. He loves his sweet tea. And then he does eat some snacks here and there. He really doesn't eat a lot of fruit or vegetables. Really, he just really likes that southern diet. So, anyway, as far as his blood sugars, he says that his blood sugars have been really high, greater than 200 most of the time. And his last lipid panel showed that slightly elevated LDL was 108. And HDL slightly low at 35, and his triglycerides were pretty high, but that's obvious because his diet is so bad. I mean, so we knew that was going to happen. He did tell me that he smokes a pack a day, and he's been smoking for about 20 years.
For follow-up, we're going to follow up in 2 weeks to assess his blood sugars over the phone, and then also how his success with smoking is going for quitting. And then we're going to follow up in the office in 2 months to get a new A1C, CMP, and lipids to see how his progress is going there.
That was going to happen. He did tell me that he smokes a pack a day, and he's been smoking for about 20 years, and he would like to quit, so I think I'm going to start him on smoking cessation treatment today. I'd like to put him on a patch and follow up with him in a couple of months when we follow up with his diabetes and his hyperlipidemia as well. Oh, but let me go back to his diabetes. I think I want to put him on Victoza. I really like Victoza because it's a shot, it's once a day, and it can help the patient lose weight. And the patient is obese, and his BMI, shoot, wish I had his BMI. I'll look that up in a minute because I really want you to know because I think it's really high. And then because he was newly diagnosed, he's going to need a pneumovax vaccine. So I would like to give that to him today before he leaves the office. And then we'll just see him in a couple months and follow up with some labs. Done. Is that okay?
Ready.
Okay, Jordan, are you ready to present one of your patients to me?
Yeah, I am. All right, I'll be telling you about the patient EP.
Okay.
So EP is a 76-year-old female. She was admitted last night for red-tinged phlegm that she's been noticing over the past week or so. And this developed with a cough about a week ago after being outside in the rain. She complains of some subjective fevers, some shortness of breath, body aches, weakness. She's had poor appetite, but she has not had any chest pain, no hematuria, no urinary symptoms. And her past medical history includes CHF, and she also has CAD and hypertension and hyperlipidemia. And for these problems, she's taking amlodipine 5 milligrams daily, carvedilol 12.5 milligrams twice a day, Imdur 60 milligrams daily, losartan 25 milligrams daily, and furosemide 40 milligrams daily. She's also on an aspirin and clopidogrel regimen, as well as a atorvastatin 80 milligrams PO nightly. She also has diabetes, type 2 diabetes, for which she's on an insulin regimen with the 70-30 NPH mix, 50 units sub-Q twice a day. She also has iron deficiency anemia, for which she takes ferrous sulfate 325 milligrams twice a day. She also has CKD stage 4. She's never smoked, really no social history or family history worth mentioning. She has no known allergies. And some of her pertinent labs today, her electrolytes were within normal limits. Her serum creatinine is a little elevated over baseline. Baseline is 2.5. Today's serum creatinine was 2.8. She has an elevated BNP and as well as a white blood cell count. White blood cell count was 13.1. For our diagnostic tests, we have so far seen a negative urinalysis. We have sputum, blood, and urine cultures pending. The urine antigens were all negative. I checked her EKG and it looked normal. The QTC was 448. The chest x-ray showed some opacities in the right lower lung and possible right pleural effusion. Today she's afebrile. All her vitals are within normal limits and she's breathing room air. And so the plan today is to continue with her home meds. However, due to the elevated serum creatinine of 2.8, we're holding the losartan today. We're also holding her home insulin regimen due to the poor PO intake.
Her blood sugar's been fine?
Yeah, her blood sugars have been fine since she's been here. They've been, her point of cares have been between 1 and 200.
Okay.
Yeah, mostly in the 120s.
And what would her goal be?
So her goal would be less than about 180
Okay.
while she's here in the hospital.
All right.
And so onto her main problem, this community-acquired pneumonia. Last night she was started on ceftriaxone, 1 gram IV daily, as well as azithromycin, 500 milligrams, which has already been transitioned to a PO. And today I recommended switching the ceftriaxone to Augmentin. The team wants to oralize her therapy and prepare her for discharge since she's looking clinically better.
Okay.
Due to the QTC of 448, she doesn't have any prolonged QTC or EKG problems, so it should be fine to continue with the azithromycin, which could cause prolonged QT. And with the Augmentin, I recommended dosing 500 milligrams twice a day rather than going with the 875 milligram dose for her renal function.
Great. Mm-hmm.
And the team wants to discharge her today with 7 days of treatment for this community-acquired pneumonia.
Okay. Is that good? Do you agree with that?
Yeah, I agree with that. We could go as short as 5 days with clinical improvement.
Mm-hmm.
However, they're ready to send her out now, so I think 7 days is reasonable, and she should be good to go after that.
Okay. Will you check her insurance status to make sure that she can get these meds or make sure she can afford them and then discharge counsel her? Where
Yes,
she goes to?
absolutely. Thank you.
All right, thanks.
All right, Lori, are you ready to go over your patients?
Yeah.
Okay, who are we starting with?
So we're starting with a 29-year-old female, and she came in with a snake bite from a copperhead. And it looks like we called poison control, and she's having a lot of swelling. And that's it.
So what did we do for the snake bite?
So I think they gave her Crofab.
What's Crofab?
Well, I haven't had the chance to look that up yet, but I was going to.
So I'm assuming that Lori didn't get the dose of Crofab. Lori, did you get the correct dose of Crofab?
Well, they gave 4 vials, but no, I haven't had the opportunity to look into how many vials is appropriate.
Okay, is Crofab the appropriate medication for a snake bite from a copperhead?
Yes.
Are you sure?
No.
Okay, Lori, maybe we should look things like that up.
Okay.
Does she have any other problems that you want to talk about today?
Looks like she's hypotensive.
And? Are we doing anything for that, Lori?
Yes, we have a sodium chloride drip.
Is that appropriate?
Yeah.
What rate should we be going at for that?
Well, we're at 100.
Okay, Lori. Are you sure you're ready to talk about your patients?
No, I think I should go review my patients again.
Well, probably so, Lori. Thank you.
Thank you.
Now get out.
Hi, Riley.
Hi, I'm back from rounds. Can we knock these patients out so I can go home?
This would not be a good thing to ask your preceptor, and you should also have on your white coat. Riley, have you put in all of your notes for the day already?
No.
Okay, do you feel like you're ready to present your patient? Do you understand them well enough?
Yes. So Miss M, she came in today with a seizure. Never seen one of those before. She's 57. She weighs 103 kilos. She's 172.7 centimeters. Her blood pressure was 121/80. And then an hour later it was 136/85. And then it got up to 156/110. Not sure what's going on there.
Did she get any medications in between those times?
Oh yeah, her medication list, she's got amlodipine 10, aspirin 81, atorvastatin 80,
No. Did she get
carvedilol.
anything that would affect her blood pressure during that time?
Oh yeah, she's got amlodipine 10.
And did she get the amlodipine 10 during that time?
I don't know, I didn't ask her.
Okay, we're going to have to work on this, Ryan. These are the things you need to pay attention to. You need to be focusing on the medications.
Okay, so back to the medication. She's got clonidine 0.1, cyanocobalamin,
And what is that?
I don't know.
Did you look this
Lovenox
up?
40, no.
I think you're going to have to add this to your list.
Let's start back from the top. Amlodipine 10, aspirin 81, atorvastatin 80, lidocaine 0.1% sub-Q, phenytoin 200, and phenytoin 300.
So, Riley, do you know if these are her home medications or are these the medications that
These are the
prescribed to her?
medications that she's on right now.
Do you know what her home medication list was?
No,
Did you talk with the patient to get her medication history?
no.
Okay, I'm going to need you to do that for your patients. You need to know what medications they came in on.
Okay.
Okay.
So anyway, back to these medications. We got a phenytoin level when she came in, and it was 2.7. And then we gave her some more phenytoin and it was 9.4. And then we gave her some more phenytoin and it was 20.
So can you tell me what all of that means?
It means we gave her enough phenytoin to make her levels go up.
Well, you're definitely going to have to do some pharmacokinetic training on phenytoin.
So while she was going up on phenytoin, she was also still seizing. So they added another medication, but I don't remember what they said it was on rounds. I forgot to take my notepad.
Riley, I thought you said you were prepared to present this patient to me.
I've got everything written down here, Dr. Cooper.
Well, it doesn't sound like you knew what medication they gave her.
It's one of these that I listed off to you. Maybe together we can figure it out.
Okay. Riley, we're going to have to sit down and review how you're going to have to present a patient and what I expect from you to know about her medications.
Well, can we go through her labs real quick? Sodium was 138, potassium was 4.2, chloride was 108, some number under the chloride was 28, BUN was 41, serum creatinine was 1.5, calcium was 8.6. I think that's all I've got. All right, we're good, right?
We're going to have some work that we need to do. We're going to go over this in more depth this afternoon. I think it would be good for you to see how to present a patient in the way that I want you to do that, so we can make sure that you are following your patients the way that you need to be doing as a pharmacy student.
Is there any place that I can look to see how to present a patient?
Yes, there is. There are some videos that are going to be available that will be very nicely done for you to watch, and that'll be exactly how I'm going to want you to follow your patients.